imagine surviving brain cancer. You know, you went through the brutal surgery.
Right, the absolute hardest part.
Yeah, and then you suffered through those grueling weeks of radiation therapy.
It's just exhausting.
Exactly. And then months later, you go into the clinic for your routine follow-up MRI. You're just hoping for the all clear so you can finally get your life back. You're sitting in the doctor's office. They pull your scan up on the screen, and there is a terrifying, bright, glowing spot right where your tumor used to be.
Which is just, your heart drops.
Your heart completely drops. But then the doctor looks at you and says, we actually don't know what this is.
Yeah.
So today's deep dive is about a literal life or death visual puzzle. We're exploring a cutting-edge 2026 medical AI research paper by 𝗏𝗏𝗏𝗏 and colleagues.
It's a really fascinating paper.
It really is. It attempts to solve this diagnostic nightmare where our most advanced imaging technology actually leaves doctors and patients in a state of, well, terrifying uncertainty.
Yeah, it's a profound clinical puzzle. The paper we're examining today is called Multimodal Classification of Radiation-Induced Contrast Enhancements and Tumor Recurrence Using Deep Learning.
Quite a mouthful.
Oh, definitely. But it gets right to the heart of how cancer treatments work and, you know, how the footprint of the cure can perfectly masquerade as the return of the disease.
Okay, let's unpack this. Because the researchers start their paper with a quote that really sets the stage for the stakes here. They write that medicine has always been an exercise imbalance between benefit and harm, precision and uncertainty.
A great way to put it.
Yeah, and nowhere is this tension more obvious or honestly more dangerous than in treating brain tumors.
Absolutely. So we are specifically looking at patients who have been treated for glioblastoma multiforme.
Usually called GBM, right?
Exactly, GBM. And this is a highly aggressive, just deeply invasive form of brain cancer. The standard of care is intense.
Yeah.
It begins with surgical resection. That means the neurosurgeon removes as much of the visible tumor mass as physically possible.
Without, you know, destroying critical brain functions in the process.
Right, which is a delicate balance. But surgery alone is never enough for GBM.
Because of the microscopic cells.
Exactly. Microscopic cancer cells always remain woven right into the healthy tissue. And that is why surgery is immediately followed by radiation therapy.
Right.
That radiation is absolutely indispensable. I mean, it is a life-saving tool designed to hunt down and eliminate those invisible residual cells.
But radiation is inherently destructive. You know, you're beaming high-energy waves directly into the brain.
Yeah, there's no avoiding that.
And its necrotic effect, its ability to physically kill cells, it doesn't have some magic targeting system that exclusively hits malignant tissue.
No, it doesn't.
It also impacts the healthy tissue it passes through on its way to the target area.
And that biological collateral damage that leads us directly to the glowing spot on that follow-up MRI.
The terrifying glowing spot.
Right, because that spot could be one of two completely different things. First, it could be tumor recurrence. The glioblastoma is actually growing back.
Which is the worst-case scenario.
Absolute worst-case scenario. It requires immediate, aggressive intervention, maybe more surgery, or a major change in chemotherapy.
Right. And the second option?
It could be something called RICE, Radiation-Induced Contrast Enhancements.
RICE-E. Which, to put it simply, is just inflamed, dying tissue that was damaged by the radiation treatment itself months ago.
Exactly. It isn't cancer.
It's basically a scar.
Right, a scar.
But why do they look identical on the screen? I mean, why is the MRI glowing in the first place?
Well, it comes down to the blood-brain barrier and really how an MRI works.
Okay.
To see tissues clearly on an MRI, doctors inject a contrast dye into your bloodstream. Normally, the blood-brain barrier is this strict biological filter.
It keeps the bad stuff out.
Exactly. It keeps things in your blood from leaking into your brain tissue. But when radiation damages the local blood vessels, that barrier breaks down.
It gets leaky.
Yes, it becomes leaky. So when that contrast dye is injected, it spills out of the blood vessels and pools right into that damaged, irradiated tissue.
Oh, I see.
And on the MRI scan, that pool of dye lights up brightly. It enhances the contrast.
But the terrifying part is that a highly aggressive, fast-growing tumor also needs a massive blood supply, right?
Exactly.
It builds its own messy, leaky blood vessels. So it also breaks down the blood-brain barrier. It also leaks the dye. And it also glows.
You've got it. To the human eye, even to a radiologist who has looked at tens of thousands of brain scans, a glowing pool of dye from radiation damage and a glowing pool of dye from a returning tumor look virtually identical.
That's just wild.
They are often completely indistinguishable. So when a patient presents with this glowing spot, it triggers a massive, highly stressful workflow in the hospital.
Like an emergency committee.
Basically. An interdisciplinary tumor board has to convene. You have oncologists, neuroradiologists, neurosurgeons all sitting in a room.
Just staring at these images.
Right, staring at the screens, trying to piece together a narrative. They're looking at preoperative imaging, comparing it to postoperative imaging.
Debating the timeline of the radiation therapy.
Exactly, and cross-referencing all of that with the patient's current physical symptoms.
I was actually trying to picture what this feels like for the medical team. And it's like, imagine you're in a helicopter looking down at a fresh scorch mark in the middle of a dense forest.
Oh, that's a good way to look at it.
Right. there is smoke rising. And you are trying to figure out, is that smoke a dangerous new wildfire starting that requires you to drop water immediately? Or is it just the harmless, smoldering embers from the controlled burn you intentionally set last week to clear the brush?
Yes.
From the sky, the smoke looks exactly the same. But if you make the wrong call, the consequences are disastrous.
They really are.
Because if you treat a harmless scar with more brain surgery, you cause irreversible brain damage.
Right.
But if you assume a growing tumor is just a scar and send the patient home, the cancer spreads unchecked.
What's fascinating here is the sheer irony of modern oncology. Think about the biological contradiction. The very tool we are using to eliminate the cancer or the radiation creates a physiological footprint that perfectly mimics the disease we are trying to cure.
Wow. Yeah.
Our most powerful treatment creates our greatest diagnostic blind spot.
And because human eyes and, standard clinical workflows are struggling to tell the fire from the embers.
Yeah.
And because patients are sitting in waiting rooms for weeks while these tumor boards debate their fate, these researchers decided to build a specialized tool to see what we can't. Enter RiceNet.
RiceNet. It is a multimodal 3D deep learning approach specifically engineered for this exact dilemma.
Okay.
At its core, the architecture is based on a ResNet 18.
Okay, let's translate that for anyone who isn't a machine learning engineer.
Good idea.
A ResNet, or residual network, is a specific type of AI architecture that is incredibly good at looking at complex images without losing the tiny, subtle details as the data gets passed deeper and deeper into its, artificial brain.
Yeah.
But the key here is that RiceNet isn't looking at flat 2D photos, like an AI that categorizes pictures of cats and dogs on the internet.
No, not at all.
It is processing full 3D volumes of the human brain.
And that distinction is crucial. When you take a digital photograph, the image is made up of millions of flat, tiny squares called pixels.
Right.
But an MRI is a three-dimensional map. It is made up of voxels, volumetric pixels.
Voxels, okay.
Imagine a Rubik's Cube made out of millions of microscopic blocks. The AI has to analyze the spatial relationships, not just up and down or left and right, but deep into the tissue.
That's a lot of data.
It is. RiceNet is adapted specifically for this volumetric medical image classification. And the multimodal part of its name is where the true innovation lies.
Because it's looking at multiple things at once.
Right. RiceNet doesn't just look at the single, scary MRI with the glowing spot. It simultaneously ingests three completely distinct 3D inputs.
Right, the three inputs. First, we have the post-operative MRI. This is the scan taken right after the surgery.
Establishing the baseline.
Exactly, the architectural baseline of the brain before any radiation even begins. Second, the event MRI. This is that terrifying follow-up scan we've been talking about.
Where the glowing spot is?
Yeah, where the new spot is detected. And the third input is the absolute game changer here, the radiation dosage map, or RD map.
The RD map is not a photograph. It is a highly precise mathematical 3D model detailing the exact spatial distribution and the cumulative dose of radiation that the patient's brain received during their therapy months prior.
It's like a digital ghost of the treatment beams.
Like a perfect description. So RiceNet is taking the anatomical baseline, the current visual problem, and the invisible map of the treatment, and analyzing them all together as one cohesive spatial environment.
Now, what makes this a massive breakthrough for actual hospitals is the type of MRIs they are feeding into this system.
Yes, this is huge.
The paper points out that previous research teams have tried to solve this rice versus tumor problem using incredibly advanced, highly specialized diffusion MRIs. But RiceNet uses conventional T1-weighted contrast-enhanced MRIs. Why is that distinction such a big deal?
Because conventional T1-weighted MRIs are the global standard of care. They are the baseline scans that every hospital, every specialized clinic in the world already uses for neuro-oncology follow-ups.
Oh, so it's accessible.
Exactly.
Yeah.
If you engineer a brilliant AI that relies on rare, extremely expensive imaging techniques that most local clinics don't have the machinery to run.
Then nobody can use it.
Right. Your AI is essentially an academic paperweight. It is useless to the average patient. By utilizing standard clinical data, RiceNet is designed to be deployed directly into everyday clinical practice without requiring hospitals to buy $1-million upgrades.
Wait, if the event MRIs look exactly identical to a room full of human doctors, how is throwing those same images into a standard ResNet 18 going to magically find the difference?
Well,
I mean, we just spent 10 minutes establishing that the dye leaks exactly the same way. If the visual data literally isn't there for a human eye to see, how does the AI create an answer out of thin air?
that's the thing. The AI isn't creating data out of thin air. It is recognizing patterns across time and space that human biology simply haven't evolved to perceive.
Okay.
First, it is analyzing the longitudinal evolution.
The timeline.
Right. By feeding it both the postoperative baseline and the current event scan, the network is calculating the highly complex trajectory of tissue change over time in 3 dimensions.
Oh.
But most importantly, it is constantly cross-referencing that visual evolution with the unseen environment, the radiation map.
Ah, the RD map.
Exactly. The human doctor is looking at what is glowing. The AI is mathematically correlating the exact intensity and shape of the glow with precisely how much radiation that specific millimeter of brain tissue absorbed 90 days ago.
Okay, but if you're a doctor, how do you know the AI isn't just getting lucky?
You have to test it.
Right, how do you know it actually understands the biology? To prove exactly how and why the AI is pulling this off, the researchers didn't just train the final model, pat themselves on the back, and call it a day.
No, they couldn't.
They had to essentially break their own machine. They tore their creation apart, piece by piece, in what the machine learning world calls an ablation study.
Ablation experiments are the gold standard for understanding the mechanics of a deep learning model. You take the fully functioning, highly accurate system, and you systematically strip away inputs or internal components.
Just to see when it fails.
Exactly, to see how and when the performance collapses.
It's exactly like trying to figure out how a complex recipe works by removing one ingredient at a time.
Well, like that.
You bake the cake without sugar, and it tastes awful, so you know sugar was doing a lot of the heavy lifting.
Right.
You bake it without vanilla extract, and it's a bit bland, but still functions as a cake. So vanilla was just a bonus. The researchers are essentially removing data ingredients to see what causes the AI's diagnosis to fail.
And to run this ablation study, they utilized a cohort of 92 glioblastoma patients from the University Clinic Heidelberg.
92 patients, okay.
They used 80 of these patients to train and validate the AI, exposing it to an equal mix of true tumor recurrences and true 𝗍𝗍 cases.
And the other 12.
They took the remaining 12 patients and locked their data away in a digital vault as an independent test set.
So the AI never saw them.
Never. Keeping that test set completely isolated is vital. You cannot test an AI on the same patients it studied. That would be like giving a student the answer key before the exam.
That makes sense.
The independent test set proves whether the model has actually learned the underlying biological patterns or if it just memorized the training data.
So they start the ablation study. They force the AI to try and diagnose the patients using only the single event MRI, just that one scan with the scary glowing spot.
The hardest test.
And the result. It generated a macro F1 score of 0.58. Now let's define that metric. What does an F1 score of 0.58 actually mean in plain English?
An F1 score is a metric that grades an AI on two competing factors: precision and recall. Basically, when the AI cries wolf, is there actually a wolf? And conversely, did the AI miss any actual wolves that were hiding?
Okay.
A perfect score is a 1.0. An F1 score of 0.58 means the AI is throwing massive amounts of false alarms or missing the tumors entirely.
So it's struggling.
Immensely.
Wow.
It is barely performing better than flipping a coin to distinguish the radiation scar from the cancer.
Wow.
But this perfectly mirrors the human clinical challenge. The isolated image of the glowing spot simply does not contain enough mathematical information to make a safe medical decision.
Next, they tested it using only the post-operative MRI, just the baseline scan from right after surgery from before the new glowing spot even existed, and it scored a 0.70. That is significantly better than looking at the actual problem itself.
Which is an incredible finding that really demands attention. It suggests that the post-operative anatomy alone encodes early, invisible markers of risk for developing radiation necrosis later on.
Wait, really?
Yeah. The AI is picking up on subtle vulnerabilities in the tissue structure before the radiation beams even hit the patient.
Here's where it gets really interesting. They then asked the AI to make the life or death diagnosis using only the radiation dosage map.
Yes.
No pictures of the brain anatomy, no picture of the glowing spot, just the mathematical 3D ghost of where the radiation beams intersected. And it scored an impressive 0.78.
Let's pause on that result, because it completely upends how we think about diagnostics.
It does.
The mathematical map of the treatment is actually a far more powerful predictor of what is currently happening to the patient than the photograph of the problem itself.
I really want to let that sink in for a second. The ghost of the treatment from 3 months ago is more visible to the machine than the physical tissue sitting right in front of us.
If we connect this to the bigger picture, this is a profound revelation for oncology. It suggests that clinical tumor boards, for decades, have perhaps been overly fixated on analyzing the visual appearance of the lesion on the screen.
Because that's all they could see.
Right. But this data proves that the true diagnostic power lies in the spatial and dosimetric environment created by the treatment. The context is more important than the symptom.
And of course, when they put all the ingredients back into the recipe, when they finally let the AI use everything together, combining the event MRI, the post-op baseline, and that crucial radiation map, the performance skyrocketed.
It was amazing.
On the independent test set, the ensemble model achieved a massive 0.916, essentially a 0.92 F1 score.
That level of accuracy is phenomenal. It demonstrates that while the radiation map is the most powerful single predictor, combining it with the actual visual evidence of the lesion creates a deeply synergistic effect.
They work together.
Yes, the modalities are complementary. They fill in each other's blind spots.
But an F1 score of 0.92, as fantastic as it sounds for a patient hoping to avoid unnecessary surgery, it leads to a completely different problem in the medical field. Exactly. Doctors cannot and absolutely should not blindly trust a black box AI. If a neurosurgeon is going to drill into your skull based on what a computer says, they need to know why the computer is saying it.
Interpretability is arguably the single biggest hurdle preventing AI adoption in healthcare right now. A high success rate on a spreadsheet is meaningless in a hospital.
Nobody wants to be the guinea pig.
Right. Clinicians need a transparent mechanism to verify the model's reasoning before they bet a human life on it.
So the researchers used a technique called occlusion sensitivity maps to peek inside the artificial brain of RiceNet and force it to explain itself.
Occlusion mapping is a very clever, highly visual technique. You take the 3D data volume that you are feeding into the AI, and you systematically mask or hide tiny cubic regions of it.
Going back to our recipe analogy, it's not just removing the sugar entirely. It's like playing a memory game and someone covers a specific square.
Right.
It's like dragging a tiny digital black box across the 3D scan, obscuring small pieces of the brain millimeter by millimeter.
The researchers are essentially asking the AI, if I blindfold you to this specific 3-millimeter cube of the radiation map, does your diagnosis change? If the AI is predicting radiation-induced contrast enhancement with 95% confidence, and then you hide a tiny piece of the radiation map, and the confidence suddenly plummets to 40%.
Then you know that spot was important.
You know the AI was heavily relying on that exact 3-millimeter cube to make its final decision.
And when they generated these resulting heat maps to see exactly where the AI was looking, what did they find? Was it looking at the right things?
The heat map showed a strong correlation exactly where you would hope a human expert would look.
That's a relief.
Very much so. The model's attention was intensely focused on the high-dose radiation regions within the RD map, and it was cross-referencing that data by focusing directly on the new contrast-enhancing lesions in the event MRI.
So it wasn't just finding some weird artifact in the corner of the scan or looking at the shape of the skull and using that to cheat the test?
No, not at all.
It was literally doing the multimodal reasoning it was designed for. The heat map proved it was thinking. This exact spot is glowing, and it is sitting perfectly inside the hottest, most dangerous zone of the radiation map.
This raises an important question for the entire future of medical diagnostics. It proves that we can build AI that is not only highly accurate, but also highly transparent.
Which is exactly what doctors need.
Imagine the relief for a tumor board. When they're presented with RiceNet's conclusion, they don't just get a binary tumor or rice label from a machine.
Just a cold printout.
Right, they get a vivid visual heat map highlighting the exact spatial interactions that drove the diagnosis. It provides the biological why the doctors need to actually trust the tool.
Okay, let's bring all this together.
Right.
RiceNet takes standard clinical data that hospitals already have basic MRIs and treatment maps and turns an incredibly stressful, weeks-long guessing game into a highly accurate, transparent science.
It's incredible progress.
But we do have to be objective and look at the limitations of this study before we declare the problem entirely solved for patients tomorrow.
Yes, and the authors of the paper are very transparent about their limitations. First and foremost is the small cohort size.
92 patients.
Right. 92 patients is a robust sample for developing a highly complex 3D multimodal model from scratch, but it is still a small number in the grand scheme of statistical confidence. You can actually see this statistical uncertainty in their performance gaps. The model scored noticeably higher on the 12-patient independent test set than it did during its broader cross-validation training phases.
So there's a bit of variance there.
Smaller datasets always carry the risk of variance.
They also note that their specific method of combining the 3 different inputs, which they call channel-wise fusion, is relatively simple.
Very simple.
Think of it like taking 3 transparent sheets of plastic, one with the baseline MRI, one with the event MRI, and one with the radiation map, and just stacking them directly on top of each other. They acknowledge that developing a more advanced mathematical fusion technique might uncover even deeper, more complex biological interactions between the radiation dose and the changing brain tissue.
And crucially, this model was developed and tested entirely on data from a single institution, the University Clinic Heidelberg. For RiceNet to become a reliable global standard of care, it requires extensive multi-institutional validation.
It has to work everywhere.
Exactly. It needs to prove it can maintain that 0.92 F1 score on MRIs taken by different machines, manufactured by different companies in different hospitals around the world, all running slightly different imaging protocols.
So what does this all mean for you? Even if you never have to deal with the nightmare of a brain cancer diagnosis, and we certainly hope you never do, this paper represents a monumental shift in how we approach healthcare as a whole.
It really does.
We are finally moving away from just staring at a single snapshot of a problem in isolation. RiceNet proves that the future of medicine lies in analyzing the entire spatial and historical timeline of a patient's treatment.
Beautifully said.
We are moving from looking at the smoke to understanding the exact history of the forest.
That is the true paradigm shift of this research.
Yeah.
We have spent centuries diagnosing diseases by looking directly at the symptoms in front of us.
Right.
But this deep dive leaves us with a profound realization. If an AI can use the invisible spatial history of a treatment like a radiation map to diagnose a current problem better than the actual photograph of the problem itself,
Yeah.
what other hidden maps of our medical history, our environments, or our past treatments could be used to predict our future health long before the symptoms ever appear on a scan?